everyone on the phone, we're working on the sound in the room.
This one that's taped.
Is it, if one just disconnected, does the others fall off? No, there we go.
It's like Christmas lights.
And they're blinking too, is that a?
Yeah, I don't know about that. I've never
Work.
seen them blink.
They blink and then they go.
You can blame it on the fire.
How long do they
Blame
blink for?
everything on the fires.
Oh, just a few seconds.
So you've seen this happen?
Yes.
Okay.
Do you feel better now?
I
Before the
believe you.
meeting started.
Maybe unplug it and plug it in.
That's what I just did. You wanna
From the
unplug
source?
back of each one.
That was when Eli's had, was the only one. Did you get it back in? There we go.
Right now?
1, 2, 3, 4.
5, 6, 7, 8.
Okay.
Well,
I fixed it.
very good.
Nice job. That's that technical stuff.
Thanks to timely technical support from Dr. Schwartz. I'll welcome everyone to our September meeting of the Public Health Advisory Board on a smoky day here in Portland, but actually farther east it's even smokier, so I consider ourselves lucky to be breathing okay here at the moment. So today we actually have a few people in the room and a significantly larger number than usual people on the phone, in part because they're dealing with some of the fire situations from around the state. So let's see, I'll talk about the agenda in just a minute, but I think what I'd like to do is ask everyone in the room to introduce themselves, and then the folks on the phone, and Carol will count up and see if we have a quorum for approving minutes and other items that require a vote today. So my name is Jeff Luck, Florida State University Chair of FAD. Rebecca, why don't we start on your end?
Rebecca Pavlak, Director of Public Policy with the Oregon Association of Hospitals and Health Systems, and I fill the healthcare seat that's not a CCO.
Katrina Hedberg, State Health Officer with the Public Health Division.
David Banksburg, Dean of the OHSU PDSU School of Public Health.
Lillian Shirley, Oregon Health Authority Public Health Director. Muriel Neilburn Brown, Public Health Director in Crook County.
Eli Schwartz, Chair of Community Dentistry at OHSU School of Dentistry. I can never remember what I represent.
And who do we have on the phone from the board, please?
This is Alejandro Corral. Sorry I can't be there. Representing members of the public.
Hi, this is Terry Tollifer. I'm the Director of North Central Public Health District serving Wasco, Sherman, and Gillum counties, and I represent the smallest counties, and I'm kind of trapped in the Dalles right now.
Right.
Hi, this is Akiko Saito. I am the state employee representative on the FAB, and I am on phone today because We are responding to the wildfires for our emergency support function 8, which is health and medical. Thanks.
Hi, this is Carrie Berjati calling in from Union County representing Clove.
Okay, and then I think Eva's going to join us
Yes, potentially late.
a bit later. Okay.
And this is Nancy Martin from Multnomah County Addictions and Mental Health Division, and I'm just representing the public. I'm not on the board.
Okay, thanks. Alrighty, so good. So we do have a quorum. That's good. Why don't we take advantage of this to approve the minutes? We actually had minutes from the May meeting that we were not able to vote to approve, and also the meetings from our minutes from our last meeting in July. So
I'll be happy to move the May minutes. I was there. I wasn't at the July meeting.
I can move the July meeting.
okay. Karen, do we need to vote on this separately, or? Okay. Well, all right. So we have a motion to approve each of the minutes. Any second?
Second.
Second.
Thank you. Okay, great. Any further discussion of changes or additions to the May minutes?
Oh. I changed to July. Me too. I wasn't here in July, so.
But I was.
I
I wasn't the July meeting.
Right. Yeah. And I actually have one to the July as well. But anything for May?
So you actually won't see the May minutes in your packets. I apologize for that oversight. We
I saw
supplied them
on
last
saw them on the
month, yeah.
computer when I was checking.
Yeah.
Yeah. I just wanted to mention that I know that we had a discussion about how the minutes were made. I mean, what they looked like and how understandable they were. And I just wanted to say that it was actually possible to understand what happened at the meeting when I read the minutes. So I thought that seemed to be a great new format.
Good. Okay. I think we thank Angela for that. Excellent. Okay, I guess there are probably some suggestions about the July minutes. Rebecca?
Yes, I was not present, so.
Oh,
we
you,
need to
that was
change.
the, oh, you were not.
We need to just
Oh,
say that I
I
was
see.
not present.
Right, and I was.
Yeah.
Didn't insert me for.
Yeah.
Oh.
And again,
That
the
probably
notes were
happens all the
great. It
time.
was
People
very
get you
easy
guys
to
mixed up, you know,
understand
it's like-
for missing a meeting. It was great notes, Angela.
Yeah. For those on the phone, Katrina has glasses.
That's the only difference, that's right. That in a couple of years.
I did have one correction, if I could, please. It's on the section about suicide. The second to last paragraph of the section about suicide, it said that I asked about whether data are available on completed suicide among individuals who sought mental health assistance within the prior 2 to 3 weeks, and that was stated as 30 to 40%. What I had asked is, among individuals who completed suicide, how many have sought mental assistance in the prior 2 or 3 weeks? So it's not that getting mental assistance is followed by a 30% suicide rate. Okay, thanks. Other changes or additions? Okay, hearing none. All in favor of approving the May minutes, please say aye.
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 Any opposed? Okay, so the May minutes are approved without unanimously. And then all in favor of approving the July minutes as amended, please say aye.
Aye.
Any opposed? Okay, so those are also approved. All right, well, thanks, everyone. I'm glad to get that taken care of. So we actually have a relatively limited number of items today, but some of them are more in-depth. The welcome and updates has actually several substantive issues that we'll talk about in sequence. We'll hear updates from Kara and Lillian, for example. Then we'll move on to updates from the Accountability and Metrics Subcommittee. And then we have a representative of the Health Plan Quality Metrics Committee to talk to us about that committee, just so that this board is aware of the interface between the two committees. Then we'll hear a presentation about evaluation of tobacco programs and some implications of future tobacco funding for this board. And then after our break, we have a couple of items, and none of those items before the break require board action. There's two items afterwards that require board action. Guiding principles for public health and healthcare collaboration is something that we deferred from our last meeting, and I hope that we'll be able to have the discussion and approval and voting on that after a couple of tries. And then finally, the FAB charter has been reformatted, not changed in content. Carol will tell us about that, and hopefully we can approve that as well. And finish about 3:30. So, thanks. Okay. That said, the first change that FAB members have heard some details about is some leadership changes at Oregon Health Authority. There was a memo by the new director that was shared with FAB. But Lillian, could you tell us a bit more about those changes and the implications for public health, please?
Sure, glad to. I hope everybody had an opportunity to see the memo and read it. I think if you did, you got a sense of Patrick Allen's style and his approach, which I think will be very positive. I've had an opportunity already to meet with him and to go over the scope of the Public Health Division as well as our work in progress, and this is obviously one of the big areas for that. The question, if you have any questions, I'll just hold it. I'm conscious a little bit at the time we started a little late. But just to say, we feel that he has moved quickly to fill any gaps in leadership that have happened. The people that he's bringing have very good reputations. I only don't know one of them, and that is Dawn Jagger, who he knows very well and has worked with him and will be doing the communications, public health, not public health, OHA communications office will be reporting now to Patrick. It won't be a separate division if people want to get that kind of organizational structure. We have two, we are splitting, as you noticed in the memo, we will have a COO and a CFO. And the CFO is also an actuary and has worked with, from the Insurance Commission perspective, she was also a part of our journey in setting up all of the Affordable Care Act work that was done. The non-Medicaid Affordable Care Act was moved over to DCBS. So the familiarity with all of that work is, on board, been there from the beginning. And those are permanent positions, the CFO, the COO. Our new interim director has made it very public that he plans to apply for the permanent position. And the other interim positions will be Leslie Clement, who you may know has been the head of health policy and analytics. But Leslie was also the Medicaid director in our neighboring state of Idaho for 5 years. So she's very intimately involved in Medicaid and Medicaid waivers and all of those things. And her work here, even before she was the head of health policy and analytics, she's very intimately involved in how we contract with CCOs, et cetera. And she will be moving over there to look at the organization and the structure as we have our recruitment for permanent Medicaid director in Health Systems Division. And then the other big change, of course, is Jeremy Van de Hey is moving from the governor's office, and he will be running health policy and analytics. And for those of you who don't know, Jeremy was very intimately involved with healthcare transformation. When I was on the Health Policy Board, he worked very closely with the governor and with Bruce Goldberg in setting up the CCOs and the work with all the hospital systems. And then he actually worked for Kaiser. And as you all know, Kaiser was an early person to sign on to the CCO model through one of our CCOs as a full participating member. And then Jeremy was brought into the governor's office with the ascension of Governor Kate Brown. And we're very excited that he's accepted this challenge because he knows our work very well and has worked with all of us very, very intimately and understands like the purpose of the transformation effort. And then as far as the Public Health Division goes, I would say that Director Allen is very clear. He understands our work. He understands population health. He has a lot to learn about the specifics of what we do and our relationship to the broader system, both the counties and the community-based organizations, how we have a vision for our work. But he's very open, and I'm really looking forward to working with him and working with this whole new team. So just leave it at that in case anybody has any questions.
David, Lily, thanks. Do we know how long the interim will be in place before selecting the permanent, and what the timing is in relation to the CCO contract renegotiation?
No, short answer. But other key recruitments like the Medicaid director, the chief medical officer, et cetera, are in process and will continue. And then the other major recruitment for us at OHA, which doesn't impact us so much here at our public health, book of business, is the state superintendent, and those are continuing.
Do you know who took Jeremy's position in the governor's office?
There hasn't been an assignment yet, but Victoria Dumchek has been in that position with Jeremy for about, I'd say, 4 to 6 months because of the workload and because Jeremy was pretty much taken, his time and brain was all taken up with Medicaid waiver and then with the Medicaid rate setting, et cetera. So she was brought in and given the task specifically to be the liaison for public health, et cetera. So we've had a great working relationship with her as well over the legislative session. But we will, we got the information out to you guys as soon as we got it, and we will continue to keep you apprised in the interim and not wait for our meetings.
Is that Victoria from OPCA?
Yes.
Yes.
Oh, yes, I'm sorry, yes.
Yes, that was what she did beforehand, yeah. So, glad you know her. Yeah.
Good. That was oral though.
Oh,
That's very good.
So do any members on the phone have any questions about the OHA organization changes? Okay, well, thanks for the explanation, Lily, and for sharing the memo with that. So yeah, let us know if there's any other, if anything changes with regard to public health division.
It's a journey, and we're all in it together, and I guarantee you will be apprised.
Thanks.
Active transplantation.
So the next update item we had was about the state health assessment. And that just, there's been, the last couple of months, there's been both quantitative and qualitative work. Alejandro and Rebecca are members of the steering committee for that, and of course Katrina's leading that whole effort. So would one of you guys be able to give us just the short summary of what you guys have been up to for the last couple of months?
So, if Kara would like to give the big picture overview, then we can chime in, so on kind of the content areas, because there are many, many moving parts.
Yeah. So several months ago, I know we brought our initial plans for the state health assessment. So this is the statewide corollary. Many of you are involved at the local level in community health assessments and community health improvement plans. So Public Health Division is on its path to complete our next state health assessment. We have a really engaged steering committee that's helping lead the process. Rebecca and Alejandro are both sitting on that. And so we had our first in-person meeting in July, and since then kind of broke up into a couple of subcommittees, one of which is tasked with looking at our quantitative data. Katrina can talk a little bit more about that. And then another group that's really looking at all of the existing data around community needs assessment, trying to look at themes for those, both community health assessments, but also other statewide community listening session reports. That group has also helped us think about how we take what we've learned so far back out to communities and hear from them, and really how we think about that, not necessarily as a y'all come and typically tend to engage the same people that have already participated in other community listening sessions to date, but we're really focused on trying to bring voices to the table that are experiencing health disparities, those voices that maybe we can't necessarily tease out of our quantitative data, and make sure that we have them represented as a part of our assessment process. So I think we've done a lot of learning along the way and have engaged a lot of non-traditional partners, which is really exciting. And we will be reconvening the steering committee next Monday to continue the work. Do you want to add anything, Katrina?
Yeah, just very briefly, I think I spoke to this group earlier, that we have our state population health indicators that we're in the process of updating. The feedback, and Rebecca and Alejandro can chime in, but was while indicators are fine, it really needs to be done in the broader context both of social determinants, structural determinants, I learned a new word, but also the context, so really kind of pushing down on, the freedom impact pyramid, et cetera. So we will be spending a fair amount of time, again, updating indicators, but really thinking about what the context is that sort of to improve the health of all Oregonians needs to not be addressed the topic-specific things, but rather this larger context. So that was the thrust, and I think we're having another meeting. Anyway, there's a bunch of opportunities to provide input, both with SurveyMonkey and in-person meetings, and then again, we're really looking forward to the community engagement meetings that'll happen around the state, which will both be this like quantitative as well as what the qualitative committee. So I do.
Yeah, the only thing I would add, I think from the FAB perspective is framing the framework for the indicators will be around the modernization framework. So I can't remember what it was previously, but we switched it.
Yeah, so the previous version was the county health rankings, which really talked about sort of the outcomes and then the behaviors, but also environmental conditions, et cetera. I still think that's a terrific framework, but I'm very supportive of the fact that since we're going through modernization here in Oregon, so one of our tasks, of course, is to map indicators that were in the county health ranking framework, map those now to the modernization framework and see whether there are any gaps with the modernization framework for, again, some of the indicators. So yeah, so I was actually, thank you for bringing that up, but I think that really is important, that we want this work to be consistent and work synergistically, and that helps that.
Yeah, I think this part of it really interested to hear how that reconciliation goes and reframing. Alejandro?
No, I don't have anything else to add. I think it's been well said.
Good, thanks. Ely?
I just wanted to understand, what is the end result of this? Is that the SHIP?
That's correct. It'll be the next iteration of our state health improvement plan.
Okay.
Mm-hmm. Yeah, so again, I think that it's both that. I mean, the idea with the state health assessment is you look at all the things that might impact health, et cetera, and then it should inform what the focus areas for the SHIP are, but not everything that's a problem in the state health assessment or identified as an issue will be addressed in the SHIP itself. So, but yes, this assessment is supposed to help drive what the activities are to improve health.
Okay, so one more question. Just because last week I was at the Clackamas Public Health Advisory Committee, and they have just completed the CHIP. So how much? I mean, and I assume that a lot of the counties around the state are in that process of completing the CHIPs. How much do we actually look at that and take it into account?
Yes, so the qualitative subcommittee that I had mentioned took a look for all of those that were available online, took a look at what the priorities were that came out of community health assessment listening sessions with their communities so that we wouldn't be duplicating and asking those same questions again. We would have that as a thread to move forward.
Any questions from, any further questions from members on the phone? Okay, thanks, I appreciate the update. That was, it brings it alive more than just the short paragraph. So, okay, so the next couple of update items are about rules at the state level and governance at the local level. I think Kara probably will look to you to explain both of those, please.
Yeah, so also as a part of the updates we've given you throughout legislative session, we had shared with you the timeline for promulgating administrative rules related to House Bill 3100 from 2015 and House Bill 2310 that passed the 2017 legislative session. Many of you have been involved in some work groups that we established but 2 business days after Sine Die. So we really got to work on these rules very quickly, generated very good content and concepts from 2 different work groups that were looking at areas of the rules. And then we had our first Rules Advisory Committee meeting on August 16th. So David, Muriel, and Rebecca are all on the Rules Advisory Committee. If you'd like to share anything from that, I think the meeting itself went really well. We were able to get through a lot of content, and we have our next meeting next week. Anything from those of you that are FAD members on the Rules Advisory Committee?
The only thing I would say, just a lot of great conversation. I think some really good ideas come up, and just kind of working through all that I think is important. So I would just say it's been beneficial.
And Carol, what are those rules meant to be?
They'll be effective January 1st, 2018. So we have our second and last Rules Advisory Committee meeting on September 14th. We have some public hearings scheduled for those at the end of November and early December in Pendleton, Medford, and Portland. And then there will be a public comment period before the rules are filed.
Great. And will you be able to give us a brief summary of, give the board a summary of what those
Will do.
changes are? Okay, thanks.
And then I know at our last meeting we had some conversations about some changes that have been coming up at the local level around governance. I don't have a lot more to add. This is really more of an acknowledgement that there was a lot of interest across board members in hearing about some of those potential shifts. So we'll continue to kind of keep this as a standing topic as we have things to share with you. So I just wanted to note that. And then the other piece was around the public health modernization investment from the legislature for 2017-19. You all worked for several months on the concept for funding local public health authorities as a part of that work. And just to share with you that we've been doing a lot of work with the Office of Contracts and Procurement to develop the tool that local public health authorities will be able to apply for those funds. We anticipate that funding announcement will go out within the next week or so, and will be open for 45 days. So we are well on target to get those dollars out in as timely a fashion as we can.
Great, thanks. And I think that was in the minutes. The timeline was in the minutes. So good. I'm glad to hear that's still on schedule.
Kara, can you remind me, does the FAB have a role in reviewing any of the applications or in that process of awarding funding?
Yep, thank you for asking that question, Rebecca. We definitely want to have FAB involved. We also need to be sensitive to the fact that we have some folks that are likely to be involved in some of those applications. So with the permission of the board, we'll just follow up with folks that would be in a place of being able to potentially participate in a review panel after this meeting to see if you're interested and available, knowing that we have some folks that we will not be able to invite to participate.
Good. thanks, yeah, hopefully some of us can do that, that'll be, well, I'm looking forward to several applications, actually. I mean, I'm hoping we get.
Say again?
Yeah, I mean, I'm hoping we get a lot of good applications. I'm looking forward to that. Yeah. None in particular.
Are there any restrictions? I mean, in terms of, I mean, can a county apply for more than one or something like that? I mean, are there any of those restrictions?
So the criteria set forward was that local health departments would be required to apply with at least one other local health department and one other organization that would be a partner, and then being able to improve their systems for addressing communicable disease with a focus on health equity. And then there are two tracks. One is really around building capacity, and then the other is on implementation. So they would need to determine which of those tracks they wanted to apply into.
Thanks, Kara. Do any members on the phone have any questions or comments about the updates? Okay, thanks. So Kara, can we talk about the transportation
Yes.
thing later?
Oh, sure.
I was
Yep.
thinking about looking at our time and wanting to move into our next item. So we had one of our subcommittees, accountability and metrics, met in August since our last meeting, so we'll have an update from them. And Jen was going to do it. Is she on?
I can't, you want to? She's not here. I saw that, yes, okay.
I looked at the minutes. Sounds like you guys had an active discussion, so
Thank you, Sarah.
appreciate the
Always.
the update from Sarah.
Hi everyone, this is Sarah Boudreau with the Oregon Health Authority, and I'll give the update on the Public Health Advisory Board Accountability Metrics Subcommittee meeting, which was held at the end of August. So the main order of business at that meeting was to talk about active transportation measures. This board adopted a public health accountability metric around active transportation, knowing that we didn't have a real reliable measure that in place already for active transportation. So at the subcommittee meeting, we went to the subcommittee with some recommendations for what we could be measuring now, and also to hear their recommendations on building a measure going forward that'll capture everything we'd like to see in a active transportation measure. So you've got a few materials in your packet. You've got the meeting minutes, but also the materials that were provided to the subcommittee to make those decisions around active transportation. The first is a matrix that shows all of the metrics that are available now, with some pros and cons for each of them. And then there's a one-pager that lists out what OHA's recommendations are, and then we ask the subcommittee to provide feedback or approve those recommendations. And I will pause to see if Muriel or Terry or others would like to interject anything at this point.
Actually, I wasn't able to be there.
Yeah, that was eclipse time.
That's eclipse time.
Sarah, can you clarify in the matrix which one is recommended by either subcommittee or OHA?
Yeah, absolutely. So the recommendation so we can begin reporting on active transportation now was to use the American Community Surveys measure, which is in the left-hand column of that matrix. It meets a number of the criteria that the Public Health Advisory Board wanted to see in these measures, but not all of them. So right after the matrix is a two-pager, and on the back of that two-pager you can see the strengths and weaknesses of the ACS measure. So the biggest weakness was that it really only looks at commute trips, not all the reasons why people would be using active transportation. I'm sorry, commute to work trips, so not all the reasons people would be using active transportation. And then the second piece that OHA staff wanted feedback on was, knowing there's a limitation to the American Community Surveys measure, what should we be looking for moving forward? Just so we know if resources become available, or if we want to put our good thinking behind something, what direction to go. And the recommendation there was to use the Oregon Household Activity Survey as the base and build from that. So that's actually a measure that sits with Oregon Department of Transportation. So it sets us up really nicely for building out our partnership with ODOT.
So Sarah.
Hunter, I have a quick question about this last, the Oregon Household Activity Survey. It's unclear to me whether it says Travel Diary Survey of Oregon households to identify where and how they travel in a specific designated 24-hour travel day. Is that a one-point question, or is that a longitudinal survey?
I believe the intent is to move toward, the recommendation would be that it would be a longitudinal survey.
Yeah, because it seems that that's the only one that has that opportunity for us to ask over time, right? I mean, the ACS is a point in time as well, so it's not a very accurate depiction of people's behavior.
Correct.
So to your point, this is Katrina. If you look at the page 2, it looks like that survey is only conducted 1994, 2011, and 2020. Am I reading that correctly?
So that's correct, and the idea is that if more resources become available, then that's an area where we could scale up. But the base of that survey is the recommendation for what we could build from.
So I was just going to put in a sort of a note, which is that some of the feedback we got from our quantitative committee related to indicators specifically around this. So it would be great if this came up then, and something that we could report on as one of the indicators for the state health assessment as well. So it's nice to have alignment, but this was an area people were interested in.
And Sarah, this is Muriel. So I'm really interested in this too. So when you guys had the meeting, only because I wasn't there, did you have discussion about the sort of the challenges in rural when there's not public transportation and some of those kinds of things, and sort of how that measures out?
Yeah, I think that feeds into another part of the conversation. So as you may recall, the metrics that were adopted by this board in June were sort of the phase 1 of the work, but we're really in the middle of phase 2 now, which is really to dive into what all local public health can be doing to support this higher level measure, and that might look different in other areas.
Okay, and I was one of the ones who supported this measure, so I get that, but I do think it's very different across the state, so that would be the only thing to think about as we move forward.
Or are you worried the measure's biased in rural settings, or just?
A little bit, yeah. Because if you're talking about public transportation, and I talk, in a larger urban area, you have a lot of public transportation. You don't necessarily in the smaller communities, like Prineville doesn't have public transportation that comes very often at all. So that was the only reason I asked.
Wouldn't the question then define the problem rather than biased in one setting versus the other?
Yeah, I mean, and I do think, we've been really working in the smaller communities around bicycling and, other ways for transportation. So I think there's other ways to look at it, but I just want to make sure we're kind of looking at the whole state when we talk about this too.
I'm just trying to understand the lack of frequency of this study. Is that because of resources, or is it because of that's the way it's planned?
My understanding is it's resources. This doesn't sit within Oregon Health Authority. It's in a different agency. But my understanding is it's resources.
So what I'm thinking of is, so for instance, BRFSS, you are able to actually buy yourself into the study if you have specific questions that you want to have highlighted, right? I'm just kind of wondering if there were a request or a demand from a health perspective of having this conducted, wouldn't it be possible to actually work with ODOT? And maybe actually put resources into it so that it might actually facilitate some more valid information.
Yes, and are you talking about putting resources into Burfus or working together to put resources into this?
Yeah, no, I mean, Burfus is being conducted at any rate, right? I mean, on a regular basis, but I know from Burfus that you are able to actually buy specific questions or buy specific areas of interest. And I was just wondering if that same kind of system worked with the OHAS, because then maybe if we had resources from the public health field, then we could maybe add to what ODOT was doing and then getting information that would be useful for us.
Right, there's a lot of interest in coming up with a measure and a source for that information that'll meet both agencies or both
Right.
systems' needs. Yes.
I think when we do have our meeting with the Transportation Commission, this would probably be a good item to put on the agenda. But so for right now, we're using the ACS measure.
That's what
In
we'll
the
use.
immediate, okay.
That's what we'll use in the immediate.
Okay, great. Any other important things you want to say from the?
We
From the
also,
meeting?
the subcommittee received an update on that phase 2 work to define the process measures for local public health, and those will come back to this board before the end of the year again for a vote.
Okay, thanks. I mean, that subcommittee continues to be busy, so thank you for, you guys did a lot of work to develop and narrow it down to a large set of measures, and you're rewarded for that by actually doing more to implement, so thanks. So another, one thing we, in the context of measurement, I thought it would be good for FAB to understand a bit about one of the other measurement efforts that's happening statewide. We've talked about metrics, the CCO metrics and scoring committee on a few occasions. Ely Schwartz is a member of both FAB and metrics and scoring, and so that helps provide a conduit between those two groups. But there's another group called the Health Plan Quality Metrics Committee, which was established in legislation and has gotten up and running in the last few months, with responsibility for broader, I guess, oversight and boundaries, I guess, explicitly boundaries on which measures can be used, can be required for use by health plans with government funding in Oregon. So I'm a member of that committee. Sean Parkman, who works in the Public Health Division, is the vice chair of that committee. So Sean is actually going to tell us a bit more about the Quality Metrics Committee with a focus, on what does it mean for public health. So thanks, Sean.
Yeah, thanks, and thanks for the invite today. So I'm Sean Parkman. I'm actually presenting twice today, so I'm wearing two different hats for the two different presentations. So the hat I'm wearing right now is vice chair of this committee, this Health Plan Quality Metrics Committee. And the reason why I'm on that committee is because one of the other hats that I wear is that I'm vice chair of the Public Employees Benefit Board. And the head board is required to have a representative on that committee. In your packet, there's quite a bit of information. I was going to give you some highlights from that, not go over every single detail. But if we go ahead and go to the next slide. So just give you a little bit of the background. So this committee was created by Senate Bill 440 in 2015. Establishing the committee, it is intended to be a single body to align health outcome and quality measures used in the state. And to be a little more specific, because that sounds pretty big, and it is big. It was intended to be big. But to be a little more specific, it's particularly focused on health plans that are publicly funded or have any kind of public funding around it. So that's the idea. There are specific criteria that the legislation requires us to consider. Go ahead in the next slide. So the idea of the committee then is, just in summary, is it's supposed to consider various criteria, various measures, metrics that are already in use, that already have evidence behind them, by and large, and to create a list of approved metrics for the state. The idea being that no other committee, metrics and scoring or what have you, can choose a metric that this committee didn't have on its list. So one of the intentions of the legislation, as I understand it, was essentially to limit the universe of potential metrics that, in particular, health plans are needing to respond to. So, for example, if a health plan, a CCO, is being required to measure from PED, diabetes rates or assessment or something like that. And then OEB is also doing that, but they're asking them to measure it a slightly different way. That creates a administrative burden. And then if there was somebody, like Medicaid was asking for the same thing, but they tweaked it a little different way, and so they're measuring diabetes prevention in 3 different ways. That's creating lots of headaches, and so the idea of the legislation is basically that this committee sets the expectation of the way the metric is going to be measured, and no one can deviate off of the list. They don't all have to choose everything that this committee puts or selects, but they can't choose something that the committee didn't select. Does that make sense? Okay.
Questions?
Yeah, please do, because the rest of the slides are really kind of more heavy detail.
So how are the metrics introduced to that list? And what's the role of the Public Health Advisory Board in influencing that list?
Yes. So that's really...
If we say we wanted to, in order to promote public health, wanted to move towards population metrics or additional upstream metrics or metrics that are related to social determinants of health, unpack it a bit. What would be the process for recommending a metric and being considered to that list? Because the downstream side is if there's all the metrics are downstream outcomes, it's really hard to move the equation. Is that the right question?
What? Exactly.
Yeah.
Exactly. Well put. Thank you.
What a great question. Just to note, I didn't plant that. So, so that is something that the committee is wrestling with mightily, and there's sort of 2 forces or tensions on the committee, to be frank with you, that the legislation, I think, kind of puts in motion. On the one hand, there is an intention to use things that currently exist and that are currently being used, which tends to favor, from my point of view, a little more downstream, sort of health plan type of traditional metrics. The committee, from my perception, does have an interest in understanding more upstream possibilities for metrics. For example, in the last committee, the last meeting, the committee tabled the entire discussion about obesity metrics because we weren't at the moment satisfied with the particular metrics that were in front of us. So we're sort of inviting the Public Health Division and other stakeholders to come and give their perspective about that. And so I would say that the committee will be a long-standing committee. It's not intended to be a one-time report is given and then there's a set and then that's over. It's intended to be revisited annually. And so I'm not 100% sure if those kinds of metrics are going to be on the menu the very first year, because the timeline that the legislation gives us is very aggressive. A initial report needing to be produced by December, basically.
17.
Yes, this December, with then several months of public comment. Dramatic looking at the committee, so that
Yes.
all interested committees can weigh in on their the way that they see these metrics. So that's another formal mechanism to engage the committee. And meanwhile, there are several, including myself. Jeff is on the committee. There's other OHA personnel that are staffing the committee and also on the committee. Leslie Clements. So there's several channels to be able to continue to introduce this kind of information. But part of the reason for coming today is to be sure that this committee is aware of that committee and that we're opening some channels of formal communication for just this purpose.
So just a reminder for everybody, this is a subcommittee of the Oregon Health Policy Board, which is important because Dr. Brandsburg is our liaison and a voting member of the Oregon Health Policy Board. So we have that avenue for this group, the advisory board, to have an official kind of position on what is selected. That's one point. I have one more point.
Can I just elaborate on that one?
Yeah.
Hopefully, when this comes up before the policy board, Dr. Banksburg, you'll ask the same question, or be able to ask the same question.
My two questions are that question and then the timing, and how does the timing relate to the CCO negotiation? Because I think the most important thing is that public health has an opportunity to recommend metrics that then make it to this list that are then part of CCO renegotiation.
Well, I think that's true, and I also think in terms of the journey that we're on, I think it's reminder for us that at the very beginning, the CCO metrics, it took us like a year and I guess it was 18 months total to even get the tobacco metric engaged with the CCOs. And it's not a perfectly upstream metric, but it's that kind of, to Sean's point, that this is here to be a long-term committee. I think that we need a short-term and a long-term strategy for getting to more health and more accountability for the dollars that we spend over time.
Sean, can I ask a question on the previous slide?
Okay.
Oh, sorry. The previous slide, could you go back one? On the criteria, so I have a question about representing the diversity of patients served. So you just described 3 very different populations, a Medicaid population, a PED population, and an OED population. And is the idea that the metric would be the same for those populations that are very different that the plans would be accountable for? And I just want to make sure that that is part of this conversation, because those are very different populations.
Those are very different populations, yes. And so that is a continuous debate at the committee, yes. And one that the committee is painfully aware of. And we'll have to, I do not know the answer yet because the committee hasn't come to a settlement on that, but it's something that it's keenly aware of.
For the newbie, PEB is public employee benefits. Medicaid, I know Medicaid is, what was the third?
OEB is the Oregon Educators Benefit Board. Yeah.
And so, actually, Sean, that was a great summary, thank you. I mean, your picture of the committee, I think, was great, really on target. Rebecca, your question sort of reminds me just one sort of comment I would make on Sean's summary, that the committee right now is figuring out a lot of the details of its own work, of how to move through the process of selecting measures, selecting measures in different clinical domains as well as measures that meet these different criteria. And so it's doing that, and then at some point, it's going to sort of come back to have to think about these larger issues. So I think those of us who are on the committee are trying, in the short term to think about the measurement issues, but then I think those of us who have a public health viewpoint are trying to keep those things on the table. But at some point, Sean, this reminds me that having the quality, the first draft come back to this committee for review and comment will be really important. Sorry, David.
There should be a more formal mechanism to propose metrics to this committee so they get on the list. You've done already very impressive work on metrics, and whether it's active transportation or early childhood obesity or early childhood education, all very important public health metrics. And there should be able to utilize the expertise of this committee to introduce new metrics to this larger list, as opposed to, of the 10 things on the list, which ones are the best. If we got a list that's listed metrics that aren't very good in terms of from a public health perspective, then we can't make it any better.
So the summary from the accountability metrics subcommittee was formally presented to quality metrics committee. So that actually that was a nice output, and it was a really good format. But I guess, Sean, I would like to follow up with Margaret just to ask, how that's been factored into the committee's thinking.
I think there is definitely still room for improvement as far as formal connections between the two committees. One last thing, just on communication. If we go to the very last slide of the deck, Margaret Smith-Isa is the primary point of contact for the committee, and how things get onto the agenda, of course, has an interaction between Margaret and the two chairs, myself and the chair. So just keep it in mind if, as by way of just direct communication for suggestions and those sorts of things. Because if formal suggestions are made, then those come to me, and then I can react to it in that leadership meeting. So just keep it in mind.
I'm sorry, Lillian, and then you.
Yeah, just one thing, just to take us back to where you started, Sean, that this is Medicaid, OF, and PED. And one of the things that why I think it's worth, as much effort as we can put in terms of rolling up our sleeves, is that 42% of Oregonians have their insurance paid for by a public source of funds. That's an old number, it's about 4 or 5 years ago. But I'm sure it's approximately the same. So that the idea that, in terms of return on investment, this is a huge point, a policy point that we could get a huge investment here in Oregon.
Also, any plan on the exchange?
Yeah.
That's right.
I just had two things. So because of the breadth of the population that this quality committee serves or is going to cover, what does health equity look like, do you think, in that committee? Both in the metrics and scoring committee and in this committee, health equity has kind of become almost like a mantra. Where we have been discussing and breaking down, stratifying statistics according to racial, ethnic diversities, identifying diversity-sensitive metrics, and so on and so forth. Do you think that there will be a reasonable understanding of those kind of concepts in the committee?
That is a great question. I don't think that the committee has I don't think it's come to an agreement with itself about how it sees it. I think the different members of the committee have different ideas about health equity in general and which populations they're thinking of. I think that is an area in particular that this committee I think has a lot to say, to be influential on the way the Quality Metrics Committee evolves. But right now, it's it really is just sort of it's just a march to December. And so it really has gotten these sort of meta questions about, these conceptual questions about social determinants of health and so health equity and so on. Really, it's, to be fairly blunt, I mean, there are these formal lists of metrics that this that the specialists have, advisors have, curated across the nation, and they're in these tidy categories that are on the slide previous to this one, and it's basically just like, so look, this one's used by 8 states, this one's used by 10, so let's just march through them. There's 10 today. Let's get. So it's kind of going like that, and so the space for the committee to really consider a lot of these critical but thorny questions just isn't there yet, which is why I think we're probably looking into the future for how the committee evolves over time to address those things. But it's a really great question.
So actually what you just mentioned was sort of my second part of the question. So I heard Michael Bailey when he was giving you sort of the send-off, and which was pretty similar to when he sent off the metrics and scoring committee, and when he sent off the oral health work group committee to come up with the various metrics, which is that we have to be nationally comparable, we have to be NQF compatible, blah, blah, blah. And I mean, and that obviously kills totally innovation. And that means that a lot of the health reform work that we have been doing here in Oregon can essentially not be measured, because we cannot measure them with measures that don't exist, and we are not really allowed to create our own measures. And that, I think, that's why I had hoped that this big committee could actually come and set down its foot, and then do something different.
So that is a very insightful understanding of the way that the committee has evolved. And so I think the one of the challenges, and I do think that the chairs and many committee members share that perspective. The legislation is fairly specific, although it does have a few areas that are open to interpretation. So we did consult with the original framers of the legislation about what their intention was around innovation. And as the legislation is written, it is a bit of 2 minds. So, and so were our responses from the legislators. So on the one hand, yes, innovation. We should innovate, because we don't want to stop that. But on the other hand, things need to get aligned, and people need to stop essentially innovating, so that there's just less of it, right? And so because the plans are being pulled in different directions, I can understand that. So that was what I was alluding to earlier, that there's just sort of a natural tension in the work. On the one hand, not to stifle innovation, but on the other hand, to try to keep with the purpose of the committee, which is to create alignment and contain the universe of experimentation.
Okay, Katrina.
Yeah, so I completely agree with this around social determinants, et cetera, but back to Sean's tidy categories on you zip through, but this measure domain. If we look particularly in the left column, if you moved dental health, elite specialty over, and moved inpatient care from the left-hand column to the right, the one that FAB is primarily interested, I'm sort of overgeneralizing, but really are the ones on the left. And many of these relate to modernization. So while I agree about the innovation piece, I also think that if we have a role in aligning some of the metrics or the work that we're trying to do around prevention and mental outside behavioral / mental health or substance use, chronic, acute, these are a lot of the things that we are looking at in our modernization buckets and in our the state health profile indicators. So again, I agree with the comment. I sort of think it's both. But even if we're not, they're not looking for a lot of innovation, I think that to the extent that we can actually align or have metrics be similar to what we're doing, whether it's in the state health assessment. I understand these are processed and we're looking at outcome. But again, I do think, you know, like I say, everybody likes standard measures, and that's how come there's thousands of them, right? At some point, we ought to be able to focus and sort of see what the library is and then pick and choose from that, as opposed to creating a lot of new ones.
So are you saying that the measures are in here?
No, what I'm saying is these are domains, so I don't know because this, you know, Sean didn't drill down and say there's 2 measures in this and 3 or whatever. What I'm saying is these domains are things that I think we can work within and come up with, or we could comment on some of the measures that are in, because the left-hand domain, again, if we moved inpatient and moved oral health over, I would think that these in the left are the things that, or many, not completely, but that we are looking at. Understanding that these really don't relate to the social and structural determinants of health.
Actually, I like that. That is, thinking about those 6 domains as the sort of the main.
Well, access is actually one of our buckets, excuse me. Access is one of our 4 buckets.
Yeah, one of our
No, that's
foundations.
true.
Yeah,
Yeah.
access is.
Okay.
No, so fair enough. Again, I'm doing oversimplification.
Yeah, that's fine.
Right, I'm not drilling down to each of these. I'm just saying, is there something here that we can work with, understanding that we might want to have more around innovation? And if we are stuck with this, where might we want to give input? So again, I was kind of off the top of my head.
But so Katrina, may I just ask, does the state health assessment steering committee know about this effort?
I don't, it has not been presented this way. So I was going to say, I don't believe so.
So I mean, I think this probably, it would be good to present this information to that committee. And again, it's if there are key indicators, you know, since you all are reviewing indicators, that's sort of another group that could provide input to the quality metrics committee about important population health measures.
Yes, no, thank you. As I mentioned a little bit ago, I think one of our tasks at hand is to look at the new framework and what the indicators that we have, how those fit in. We are also getting input as to what additional indicators people might consider and what's the data source, so that's a little bit similar to this. But I would be interested in this sort of measure crosswalk, again, not just the domains, but what the measures were under here. Because I do think I appreciate this alignment. I understand the same with national and et cetera. You don't want it to be too constrained. On the other hand, you don't want to constantly be creating a bunch of new indicators that vary from year to year, because then you're not really able to track anything. So,
just want to remind you that we did actually do that crosswalk. I can't remember who of the intelligence staff who did that, but I remember this enormous spreadsheet that actually crosswalked chip and ship and pop and dop and chip and gok and whatever they are called, all of them. And it was actually very interesting, and there were a lot of overlaps, and it was very interesting to see where the overlaps were. So probably that should just be renewed.
Although I think the more concise and pointed the input, the more likely it is to get the committee's attention. So that's why I think the final document from the Accountability Metrics Committee was good, because you could just read the yellow highlights, and there's a dozen things there, and so that's something that, for example, we can refer to during discussions.
Although, I could say, I could make a staff commitment, and I'm about to get hit over the head by Karen. But since we're embarking on the community process, and since we have, many of the communities are redoing their CHAs, part of the purpose of that was to look at where the alignment was.
Yeah.
So if we had some, and I'm sure we will, problems are there, and they haven't necessarily had an enormous change in them. If we could make the argument that through these areas, this would be our recommendation for a measure within a domain, and it also represents this broader, not just community, but population work, I think that would make the argument even more powerful to the committee.
Thank you. Yeah, that would be great, thanks.
I just want to emphasize a point that Ellie brought up, and the difference between stifling versus capturing innovation. I think our overarching goal is to capture the innovation of the CCO model to the effect that it is moving, it is creating incentives to deal with upstream and population level health, and wouldn't want a sort of conservative approach to measurement and just taking the old standard measurements to prevent us from capturing that innovation, evaluating how innovative and effective the CCO model is. And so it would, in terms of Sean's point about near-term versus long-term goals, I interpret that as if we want to make changes, it won't happen for this CCO renegotiation, but for the next one. And I think that would be a wasted opportunity, is that we, these contracts will be negotiated. This is an opportunity to put metrics that are reimbursable in there that really capture the innovation of the CCO model. And this is a really important time since this is the first round of the CCOs. How well have they done? Have they delivered on the promise?
Chair Lux, this is Terry. Can I make a comment?
Oh yeah, please do. Please, yes.
Listening to the conversation, I just the reality that I've experienced around metrics is since things have tightened up and not everyone is meeting their metrics, and the emphasis is becoming getting dollars into the community to do the work, I'm seeing more emphasis on data mining and data crunching and looking at the numbers to try to make the numbers work and to meet the metrics, rather than really being honest about patient and community experience. And I would really hate to get us to a point where we're just manipulating numbers rather than actually doing the hard work to get the money delivered back to communities. And I think it's pretty astounding how rapidly that has occurred in the CCOs within just a few cycles. We've gone from being innovative and really changing the experience for the client to mining and coding data differently to get the money on the ground and ignoring the experience and access issues that patients are really having and what's going on in the community. So I think we really need to pay attention to the tension there.
Okay, thanks, Terry. Yeah, I agree. Yeah, completely. Hey, well, this this was much a richer item than I realized, but I'm really glad. I'm really glad we put it on the agenda. Thanks. So, do any other members on the phone have any questions or comments about the Quality Metrics Committee? Okay. So, Sean, thanks very much for coming to us today. I hope. I'm sure we'll have the opportunity to talk again. I really appreciate your, serving in the liaison, seeing yourself as a liaison between public health and quality metrics in a fair-minded way. Yeah. Thanks. I'm looking at our agenda. There's, Sean, would we be able to do the tobacco a bit later and move into the next, sort of a short break in the next agenda item? Yeah. Okay, because the next agenda item is one that has gotten delayed, and Safina is here, and I do not want to miss the window of opportunity. So, could we take just a? That's right. So, could we take a short break and come back at 25 after and talk about guiding principles? Thanks. Welcome back, everyone. We're going to actually make a slight switch in our order and move into our discussion about guiding principles. But we had one follow-up from the discussion we just had about the Quality Metrics Committee. Actually, a member of the board would like to make a motion to capture our recent discussion. So, David.
Thanks, Jeff. This is David Bangsford. I'd like to make a motion to recommend to the Oregon Health Policy Board a mechanism to introduce metrics from a public health perspective that addresses, introduce metrics from a public health perspective from the Health Plan Quality Metrics Committee, so we can introduce it to the list. And that this be done in a timeline that would inform the CCO renegotiation. And I think the goal here is to, make sure there are metrics included that captures the innovation of the CCO model to move upstream determinants and social determinants of health.
Thank you. Any second to that motion?
I would second that.
Thank you. Yes. Discussion. I'll just take the prerogative for the first question. So, David, this would be a motion from FAB to
Oregon Health Policy Board.
to the policy board. Okay, thank you.
I assume that's the appropriate mechanism.
Yeah, no, that makes sense. I just want to make sure.
I would communicate this during my report to them.
Great. And questions or suggestions from other board members?
This is Terry. I have a comment.
Yes.
I would hope that in that there is an expectation that then the CCOs would work with governmental public health, be it local and state, on meeting those metrics. We've struggled with work with the CCOs on population health as it is, and I think setting up a metric and putting it in their responsibility basket is only going to make that interaction more difficult when we have a statutory responsibility to population health. So I think there needs to be some sort of discussion about how that is collaboratively done.
I think that's an excellent point.
Yeah,
Okay.
great point.
Okay, good. Yes, I think that, yeah, very much in the spirit of the motion.
The only other part I would add is I would hope that the health policy board then wouldn't stifle all the work that we've been doing on our population health metrics and accountability metrics. So I want to see the alignment, but then I don't want the board to say, okay, great, then your work is done. So just, not that would go down that path, but be aware. If that makes sense.
Okay, thanks. So I guess hearing no other questions, I guess I'll ask, I'll call a vote and ask all members of the board in favor of the motion, please say aye.
Aye. Aye.
And members on the phone?
Aye.
Great. Any opposed? Okay, so that all votes were yes. Thanks, David. And thanks for the motion and for carrying it forward the policy board in your role. Appreciate it. So anyway, so back to our next item is actually talking concretely about the relationship between public health and healthcare organizations, including CCOs. So we have this board had drafted some principles for collaboration between public health and healthcare organizations. And we have a couple of new items of information. Safina will tell us about her work with Columbia Pacific CCO, and Carol will tell us briefly about her input she received from the Columbia Gorge Health Council, and hopefully we'll be able to approve these principles today. So, Safina.
Can you?
Oh, yes. And yeah, these PowerPoints are in the meeting packet.
So in Columbia Pacific CCO, again, it's Tillamook County, Clatsop County, and Columbia County. And we have the benefit of working closely, even outside of a public health perspective, with a couple of the public health directors from a community health center perspective, primary care perspective. So we already had some built-in relationships, and we've tried really hard over the last many years to build relationships with all key stakeholders and vice versa. So I just wanted to say that to start out with. It wasn't like we didn't know each other or anything like that. We've done a lot of things. But what I did was, many months ago, I kind of sketched this out for, like, maybe in the beginning of when I was first on this board, and when we went and talked to QHOC like last year, a long time ago, for QHOC, which is the meeting where all the state CCO medical directors and other people come, for them to understand what FAB was and help understand the relationship between CCOs and public health. And obviously this is overly simplistic, and obviously there's things that are on the CCO side that are also on public health and vice versa. But I made this Venn diagram to illustrate things that are like more purely CCOs and more purely public health, and things that are in the middle. And this kind of helped, first of all, the QHOC medical directors to kind of understand the interplay and where it is really important to collaborate. And then what we did within Columbia Pacific CCO is, a few months ago, the Columbia Pacific CCO brought together our leadership team and then the 3 public health directors together for breakfast for like 3 hours to start talking about more concretely and we asked them, with your public health director hat on, not your FQHC director hat or your primary care director hat. We want to talk about the best way to collaborate. So I started with this, and they gave input, and we added a few things in the middle and things like that. And then what we did was we talked about shared priorities, so more hashed out that middle section, but from much more detailed perspective. And each, like they got together, it's in one room, but they got together and kind of documented from their perspective what are their priorities under all those categories. We did the same. And then we did this ease and impact scale to determine focus areas. So there's, from the CCO perspective and from the public health perspective, and then we found where those shared priorities were together, because we wanted to then work on something concrete and not have it live in the theoretical world forever. And so we did this, and I think it was a really helpful exercise to have both the CCO and public health directors understand each other's priorities and the why. I know for me personally, it helped me understand more of the funding stream issues that may dictate certain public health departments' priorities versus the ethos of what they want to do. And so I think it helped develop shared understanding, and then that helps develop trust and things like that. So we did this, and then we came up with a few things that were fairly high priority. One of them being immunizations. And so what I did, you can go to the next one. And one of Alicia Miller on our leadership team came up with this model to kind of get more granular and move work forward. So immunizations was one of the things that was absolutely a shared priority, right? So it's a CCO metric, it's a public health priority, it makes sense. And so this is just an example again of how we're moving things forward, but this is what we decided collectively to be our first area of collaborative work. And so we defined as a group together, the priority is increase less than 2-year-olds and decrease school exclusions. The goal was to try to increase for 5%. So we decided this as a leadership team. And then together, we decided what was the core public health work and what was the core CCO work. It does not mean that that's like exclusive of each other, and then what's really, really shared that we need to work together. And then what we did is I don't have these in here. We have another version that's all populated, but the public health departments chose a lead for each of their departments, somebody who works in immunizations or whoever they decided. And then we chose a lead within our team for them to meet together and then come up with more of the work plan regarding that shared work. And then they would report back to the leadership regarding what they're gonna do. And currently, we're in that process, so we haven't done that yet. But this is the model we're gonna test it with immunizations, for example, and then see how that works, and then move on to the next shared priority work. So this is relatively new. I mean, that first meeting that we brought all of us together was maybe 4 or 5 months ago, and then it takes a million months to meet again. But so this is what we've been working on.
That's great, thank you. I mean, I really like how you sort of made it concrete and identified sort of the core tasks for each group and got explicit about shared tasks. That's excellent.
And I didn't put in here all the priorities that were identified by the group outside of immunizations, and if that's of interest, I could share that with whoever later. And the ease and impact exercise, we have pictures of it and stuff like that, but I didn't put that in.
Oh, okay.
So just, this is great. Thank you for sharing, and thanks for all that work. I mean, you can tell a lot of people were around the table to get to this. One thing I would ask Safina going forward would be interesting, particularly around the areas, public health work, CP, CCO work. You know, if we could look at some of the public health work that's here and identify it where it fits in our capabilities, our modernization capabilities. Because one question that I would have, advocacy isn't under public health work, and I see that as kind of core if we think of leadership, community engagement, chief health strategist. But it is shared, it says, but it's called out in the clinical work. So just not for now, but just maybe for a deeper understanding of exploring how to explain that as if we took it as a tool in other areas to understand.
And that might just be an oversight, like it should have been maybe removed from the clinical and just left in shared.
Maybe. I mean,
no, I'm saying,
I'm just saying. I don't know, but I think those are the kind of conversations.
Yeah.
To get to Terry's point, that having that clarity and I'm sure at least my experience with a number of clinical providers is they do think that that's their main responsibility. But if you have a small enough table where everybody's talking to each other, and I'm picking on advocacy, it could be anything else, like outreach, it could be outreach, for instance. And if we talk through at a small enough table around the state, I think we'd get more efficient use of resources, you know, and a more understanding of how we're going to, you know, just track those accountabilities.
Yeah.
You know, and I think what you've done is given us a really concrete place to work on it.
And I think from what let me just clarify what you're saying. So you're saying have conversations of where some of the shared work or public health work can also link into the state? Is that what you're saying? What are you saying?
No, I'm thinking of the local table. You have FQHCs, you have CCO, and you have county health departments. So what do they think their responsibilities are here? And beyond just the brand name, you know, say advocacy or community outreach, how do they think they're responsible for that? And what would they do and fund for that?
Yeah, so that's perfect. So just to make 100% sure, that everybody understands, everything under the public health work was determined by the public health directors. So we did, you know, the CCO didn't do that, and then vice versa. But under each of those things, we did start having some of those conversations, and then that is the point of they're supposed to come up with exactly what you're saying, like what are the details underneath each of those things to move that forward. And that hasn't happened yet. Yeah.
It's a journey.
Yeah.
So Lillian, this is Muriel, one of the things I would say as an example of that is the perinatal care continuum we're doing in Central Oregon is really an example of working with the CCO, looking at what the need was. We really looked at first trimester care and said we have some issues here. So basically the CCO helped fund, and it's also part of public health, is we have community health workers embedded at the OBGYN offices. And so they're signing them up for OHP, for WIC, getting them all resources, making the dental appointment, making sure they get what they need. They're also doing it in the WIC clinic. So we made those decisions together, and I think that's an example of this is where, you know, it improved numbers in WIC and helped people get healthier through that, but it also is making sure that people are getting into first trimester care. So I think looking at this and looking at what are the examples out there where this is really working and then sharing that throughout the state, I also think is a great idea.
Stuff like that should make it in the metrics so they get incentivized for that great work.
Well, and also, I mean, so as you know,
Where'd he go?
No, I was looking at Morgan. Is she?
No, she left.
Okay, you know, as the public health modernization roadmap is being developed, I think both of those examples from Central Oregon prenatal care and you know the Columbia Pacific collaboration, I think those would be that'd be one way to get some of those tools into broader hands, is to have them, you know, summaries like this, maybe with a little explanation like you gave Safina, as part of that roadmap.
Yeah, I want to obviously also congratulate Safina for pushing this envelope as well. I mean, this is something that I have seen as the major opportunity since I started working with first the metrics and scoring and now this FAB as well. And as Sarah has helped me to put together a presentation that we'll be giving to the Metrics and Scoring Committee at their next meeting in September. Because I had already, you know, mentioned so many times that I think people almost, you know, fall about when I open my mouth in the Metrics and Scoring Committee about the opportunity for actually working in parallel with the public health system. I mean, to my mind, there has been this kind of situation that the CCO system has this enormous amount of money, which obviously comes to the care system. And I'm aware that the CCO system has been is focusing on the Medicaid population, whereas the public health system is focused on the entire population. The problem to me has been, especially when we talk about health equity and so on and so forth, and social determinants of health, that the major portion of the population that the CCOs are responsible for are also the biggest problem for the public health system. even though the public health system formally, I mean, has the entire population at its, as its target. So in a way, I mean, I think that there is an enormous opportunity for this overlap and collaboration. I've also mentioned to the Health Share Board, where I'm also at now, that I would like to give a presentation about the guiding principles that I hope we'll be approving today, because then we have something to actually come with. And Janet has also been very interested in having that. And there it's interesting because in the CCO board, you actually have representatives of the 3 metro public health agencies. So you actually have a direct opportunity to kind of link things together at the level where it's probably most important. I mean, with HealthShare's 250,000 members, I think if we could get them moving, for instance, in relation to some of those issues, it would be a major push in relation to what we're trying to do.
Good. Thank you for taking that to HealthShare. I really appreciate that. I'll actually take that as an opportunity to move our discussion toward approving these principles. The last, the other item of information we had today was from Kara, who went to a Columbia Gorge Health Council meeting and received some specific suggestions from several stakeholders that are reflected in our draft. So Kara, could you just briefly tell us, they're reflected in track changes, so if you just very quickly tell us what the substance of those would that be helpful?
Sure. So these are just some suggested edits from the last time that we looked at these, which was in May. I think it was very helpful to get the members of the Columbia Gorge Health Council's perspective, most of them coming from healthcare, and really making sure that these resonate with them. So the first piece is in the purpose statement, just framing that this is a tool, it's a starting place, it's not the be-all and end-all for everything that public health and healthcare can do, but it is an attempt to get us started. So that was the first suggestion. And then clarifying in the guiding principles, the second value statement. The way that this was originally worded, the Health Council felt that let's put sort of an additional value on public health, or rating that higher than healthcare. So I attempted to reword this based on that feedback to be mutually supportive. Let's see here. And then the strategies section, some folks felt like this was really a list of kind of to-dos, and so that's part of that change in the purpose statement up top, that this is a starting place, these are ideas, but not a check off. You have to do every single one of these things and in this order. And then the last piece of feedback that we got was under strategies, leadership, and governance. Some feedback came in that in certain communities it may not necessarily be possible to have shared participation and official seats on governing or leadership boards. I wasn't able to unpack that too much further because I ran out of time for this agenda item, but this was, I think overall there was a shared value for participating in each other's decision making, and that being the purpose of this piece, and so maybe broadening the language a little bit to not specifically say that there has to be a seat on a governing board. So that's the last edit that's provided for your consideration. Any questions?
I just have a comment. I've shared it with all of our public health directors and our CCO leadership, and they all said it was great. And that was before the edits.
Oh, okay.
The edits make it even better.
Do any members on the phone have any questions about the suggested edits that Kara just walked us through?
Kara, would you mind repeating what was that about the governing? Or leadership and governance?
Yes.
Yeah, so the feedback that I've received was that in smaller communities in particular, it may not be possible to have an official seat at a governing table for each entity. Although there was a strong value in making sure that we call out the perspectives of healthcare and public health and one another's decision making. So that was just designed to open the strategy up to be a little bit broader than just a seat at the official board level.
Okay, well, so thanks. I would be glad to entertain a motion to adopt these principles.
So moved.
Thank you. Second.
Second.
Thank you. Is there any further discussion about the principles as we see them with the edits dated July 10, 2017?
Will we now get like a gilded framed copy of these guiding principles to put on the wall or something like that?
We can arrange that.
Yeah, I'd just add, I feel like we've been using these since
I
March
know.
or whenever we created them with our respective organizations, so it'll be good to have a final blessed copy.
Okay. Great. Well, so hearing no further discussion, I guess I will ask everyone for a vote. All members in favor of adopting the principles, please say aye.
Aye.
Aye. Any members opposed? Okay, thank you. Kara, I think we have formally adopted principles.
Yay.
Thanks, everybody.
Well done.
Yes. Okay. And thanks, Fiona.
Yeah. Thanks so much for coming in.
Great work.
Yeah, this is great. Thank you. Bye.
Yes, if not, hope everything goes well.
Yes. Keep us posted.
Okay, so let's see, Carol, we're a little bit ahead of time for guiding principles, but we skipped over tobacco. Is Sean? So, and hopefully our FAB charter template can be very, that item will be brief. So we are returning back to the agenda item that was on the item that was on the agenda for 150, tobacco prevention evaluation findings. And Sean Parkman will be talking to us with from a public health perspective, a public health professional. But Lily and Carol, would you like to set the stage before hearing from Sean, or talk about that after? Because I'll just say, there is this information from Sean is in part meant to set the stage for a larger discussion by FAB subcommittee and FAB about tobacco prevention and funding for tobacco prevention in the wake of the current the most recent legislative session. So I'll let that Lily and Kara for you guys to frame it up.
Okay, so just for context for the Public Health Advisory Board, we're going to have Sean lead us in a conversation today presenting some findings for evaluation of the Tobacco Prevention Education Program competitive grants. This is coming to you because in the 2017 legislative session there was a budget note added to House Bill 5006 that brings to the Public Health Advisory Board some recommendations on the $3.6 million loss in tobacco master settlement agreement funding in tobacco prevention. And you all will be responsible for weighing in on the impact of those reductions going forward, along with the Tobacco Reduction Advisory Committee. So this is just setting the stage for that. Today we'll hear a little bit about the evaluation and then some specific work will be happening later this month through the Incentives and Funding Subcommittee to take a look at the impact of those cuts to the tobacco prevention program, and then we'll have a final look at those recommendations at our October meeting. Did I miss anything, Lillian?
Nope, that's it.
Okay.
All right.
Thanks.
Thank you. So,
Here
the
I am
hat,
again.
yeah, here I am. The hat I'm wearing this time, I'm the evaluation lead for one of the sections inside the Public Health Division, Health Promotion and Chronic Disease Prevention, which contains the Tobacco Prevention and Education program. So, we, overall, this is about a particular type of funding model that's competitive. It's a competitive funding model, and that's what we're up to. The just a little reminder about the Tobacco Prevention and Education Program. TPEP is what we call it. It's a comprehensive program the way we've designed it. State and community interventions, health communication interventions, cessation interventions, surveillance and evaluation, and administration and management. Those are the comprehensive components of a tobacco control model. And we're in particular interested in the community interventions at this particular moment. Next slide, please.
Is that the quit line?
So that would be the cessation benefits.
Okay.
The community interventions really comprise of some funding for all the counties and tribes receive base funding for policy, systems, and environmental changes for controlling tobacco. So all of the local public health authorities are funded with some base funding in order to train themselves with our help to focus on policies and sort of permanent structural changes in their counties in order to move upstream for the purposes of preventing tobacco use. And since 2014, there's been funding provided for 2 competitive grants for local communities too. And we have called those Spark and Search. Next slide, please. So, quick sort of overview of those 2 things. Strategies for policy and environmental change, Spark. All local health departments were eligible for the competitive funds. The goal of this particular funding was to accelerate tobacco control policies, especially in the retail environment. And we ended up funding 9 grantees covering 13 counties, because different counties can apply together, consortia, that sort of thing. Next slide, please. There's another one, Search Sustainable Relationships for Community Health. The eligibility there was coalitions of CCOs, local public health authorities, clinics, and community partners. The goal of that particular competitive funding was to create sustainable, effective relationships between community partners to improve access, quality, and costs of preventive chronic disease self-management services, including tobacco cessation services. So, number of funding, we funded 8 CCOs, 10 local health departments in different formations of coalitions. But those are the core funds. Next slide, please. Okay, so those were these 2 types of competitive funds, Spark and Search. So how do we know if these worked? Next slide, please. We evaluated. So program evaluation is a systematic study using research methods to collect and analyze data to assess how well a program is working and why. That definition by the United States Government Accountability Office. Next slide. So in other words, we formally evaluated these programs to determine how effective they are. The purpose of program evaluation studies are typically requested or initiated to provide external accountability for the use of public resources to learn how to improve performance or both. Okay, next slide. So that's how we've come to these conclusions that we're about to go over. So what about Spark? How did that one go? Next slide. So with Spark, all grantees passed best practice tobacco retail policies. And Spark grantees had more advancements through the policy change process on more policies than non-Spark counties.
Sean, could you give a couple of examples
Sure.
of what this is about?
So one of them actually that just happened a couple weeks ago, as an example, is in Crook County. They passed a policy that the quit line has to be posted in all tobacco retail outlets, for example. Another example could be a local tobacco retail licensure could have been passed, was passed in several counties. The idea being that if you are going to sell tobacco, then you have to have a license to sell tobacco, and that license should have enough cost to have to be able to sustain some sort of enforcement for the county. That's another example.
Enforcement of what?
So the enforcement of youth access, other types of policy plugins, for example. Several of the communities were pursuing Tobacco 21 policies, that sort of thing. So we have if you're interested in sort of the details of this, we have a detailed report on Spark. We're giving you the highlights here. And you actually have a sort of color handout in your deck that's just a 2-pager, has a map on it at the end of these slides. Kind of gives you a little more detail, but a full report is also available to give you sort of more in depth. But we ended up having a list of best practice retail policies that they could choose from. And the majority of them were at a stage where stage 1 was to pass some kind of tobacco retail licensure, because Oregon is one of the few states that does not have a statewide tobacco retail licensure law. So the sort of main high-level results of this is that policy work we have learned over many years is hard and takes a lot of time. And we have a policy change process that we help our local grantees work through. And the Spark grantees in particular moved faster on more policies, more different types of policies than non-Spark grantee counties. Okay, so then next slide. Did search work? So the search results. All 8 CCOs and 10 local health departments implemented referral systems to the tobacco quit line. We find that to be, that's a big deal. Multiple new formal partnership agreements were secured, and several new shared projects in this particular type of project emerged. For example, electronic referrals to the tobacco quit line. Next slide, please. Some additional search outcomes. Clackamas County Individual Clinic screened 11,292 patients for tobacco use and provided tobacco counseling to over 500 patients. Lincoln County implemented a system to screen over 99% of federally qualified health center patients for tobacco. And Lane County increased to 84% the number of community health center patients with tobacco status documented. So some sort of measurable structural changes that what this project was after were these sort of permanent system changes between the relationship between local public health, CCOs, and other community partners to be able to sustain these kinds of benefits over time after the funding goes away. Okay, so in sum, we find that competitive funds are effective. That's the bottom line from our evaluations of our different types of funding models. Competitive funds allow us to pursue permanent structural changes, system changes, or policies faster than non-competitive funds. Go ahead.
So the question in terms of how you know that these changes are permanent. You make an investment to change a policy, it's implemented, you have more people, more time and attention. But then once the money is spent, how do you know it doesn't revert back to the status quo?
Yeah, that's a great question. So that's why we, so there's two answers to that. That's, the first answer, that's why we like policies so much. Once you pass a city ordinance, county ordinance or law, then those things last, they stay.
Is the money going to advocate for the policy? Is it lobbying for the policy? That seems like
yes.
We're using federal state funds to lobby for state policies.
So that is a good. I don't know.
In the name of the public health.
No, we actually have we have one of the things we've done at OSU is have a public health policy implementation seminar, and we actually touch on that. You know that we can't use federal dollars for advocacy, but developing the details of the policy, gathering the stakeholders, informing local elected officials, developing implementation plans, evaluation, those are all things that can be funded, and actually where the local health department or public health provide expertise that is necessary to make those policies happen. Otherwise
we don't have time or attention. Okay.
I'm all for it.
Okay, great.
It's all
Thank you, Jeff.
Sorry, I couldn't resist, but Sean,
No, I love
jumped
it.
in.
That's great. I'm going to take you with me. Yeah, that's right.
So this is Muriel, and being from Crook County, I know how challenging tobacco policy is in Crook County. And I have a new court, it's challenging, and we still got something through. Now, the one thing, the story I want to tell that doesn't show in the data, and I appreciate this, is that the TPAP coordinator I have has been doing this work for over 20 years. If she wasn't, when you take a 0.75 and you add a 1.0, you're probably going to see change anyway, just because you have extra people doing it. I think the bottom line for me is it was actually Chris Williams who was moving this forward and doing this work, who's still a 0.75. Whether we had the grant or not. I mean, we work on tobacco policy all the time, but I think the TPAP program itself and the work those people do, I think is really important. And I know in my county, and I also know in Deschutes County, it's still the TPAP coordinator who was pushing this work forward because they have the history and they understand the issues. So that, for me, that doesn't show in the data, kind of who's doing the work. And I think that in the counties that got that, and I'm one of the smaller counties that got it, and I appreciate it, but I also know that when you have extra people and you have extra dollars to do some work, it's a little bit easier, even though your person guides the process.
That's a great point, and allows me to make clarification. So I think, I guess to clarify, competitive funds, I think what we're finding is competitive funds is a good thing to have in the mix of funding opportunities. There's that's something to be said for the sort of base funding that we mentioned, but we've had good success with, as part of that mix is having a competitive component.
Yeah, I think that's a really great story and a great point. We have had a lot of conversations about, with the modernization framework, being able to be nimble and flexible, and so I think it is that balance. You're going to have your based funding, but when we have these opportunities to sort of turn a light switch on and get really good outcomes, I think this is a good model, and I appreciate all the evaluation work that went into it that tells that story, so thank you.
So Sean, what was the original, oh, sorry.
It's okay.
I just wanted to know what the original amount of money was that was competed about.
It was 1 million for Spark.
And 600,000 for search.
Yeah, 600,000 for search.
And I guess my comment was, and maybe you can remark, but sort of to David's point, not all of this is federal funds. Most of it is other funds from state tobacco tax, so that's a little bit different. And the other comment that I wanted to make is, you know, the words advocating for policy. Of course, a lot of what we do in public health is we implement control programs, whether it's increasing immunizations or controlling tobacco. And so that's a little bit different than lobbying legislators to have X, Y, or Z happen. But your point is well taken. It's just, it's a fine line that we have to be clear that our job is to implement evidence-based control programs, evaluate them with our other tax. And so I tend not to use the words advocacy. Again, I like the word policy, but that's a little bit different than laws or legislation. Again, there's a big overlap, but it's in part, we aren't doing anything illegal, to Jeff's point, but people tend to react to certain language. Language is important, let's just put it that way. So
We can advocate for evidence-based policies.
Yeah. And we do.
So Kara, can I read, I'd like to read this budget note. Tell me if I'm, so there's, in my facilitator's agenda, I have this little, what's called a budget note, which is something that, you know, a note written by the legislature during session. It's not, in my understanding, it's not exactly a law, but it is something that will be done. And so let me just read you. So having heard what we just heard, I'm just going to read the note, and I know that we're going to talk about this more, but I just want to actually, you know, the board members to sort of have the context into which our discussion fits. So the note says, the OHA, in collaboration with the Tobacco Reduction Advisory Committee, shall make recommendations to FAB, that's us, on reductions to the tobacco prevention to the TPEP program, which we just heard about, based on the loss of Tobacco Master Settlement Agreement funding, comma, that reflects best practices for tobacco control to minimize programmatic disruption. So in other words, the legislator says that the OHA, in collaboration with the Reduction Advisory Committee, shall make recommendations to FAB on sort of, you know, how to cope with the loss in master settlement funding in a way that's consistent with best practices for tobacco control to minimize program disruption. Then there's a second sentence to the note that says, the OHA shall report to the legislature on the impact of the loss of tobacco master settlement funding to tobacco prevention in Oregon across several dimensions, across state and local programs, health communications, tobacco cessation, data and evaluation. And if you'll notice, those are the elements of a comprehensive tobacco control program that Sean introduced at the beginning of this discussion. So that's the context in which we bring this information, and I'm sure we'll have some later discussion.
So if I understand this in non-legislative speak, our charge is say how to, this program is being cut, what changes need to be made in the program in order to minimize the impacts of the cuts?
Yes.
And what's going to happen with those cuts?
So the rest of the sentence is, it is a $3.6 million cut.
Out of how much?
Out of, what's the total?
Almost 20 million.
Out of 20 million, so it's up 20%.
Yeah, 20%, yeah.
Right. Yeah, so that budget, when it talks about the reduction of funding, it's about it's sort of how to best cope with the elimination of $1 and $5 to tobacco control programs.
Are we going to be honest, or are we going to be politically correct?
this
as
group
a,
is
as a
never
board
going-
member, you can be, whichever.
I mean,
I'm sorry, I just sort of wanted to, you know, literally read the note as what the legislature has charged OHA and us with, so, Ely, go ahead.
well, so OHA is going to come up with something, I mean, to suggest something to us, as far as I can understand. I mean, everywhere I have been, if you take money away from a program, the program goes away. I mean, unless we have money somewhere else, in some other bucket. Take some money from the $5 million we just got for modernization. I mean, but of course that's not realistic because that money is probably already used for something else, I would imagine.
According to what you guys told us to use it for.
Right, but I would say though, I mean that a part of our new accountability metrics, tobacco smoking is one of the accountability metrics. And I mean, of course we could say that of course it's not an ideal situation, but if that's the reality, then of course we could decide or we could recommend that some of the money will be used for that purpose to achieve one of the accountability metrics that we just decided on. I mean, we didn't get the money that we were, or that we had hoped for, but I mean, and it can probably not be as large a program, but it maybe could be some, grants that would still be able to give us some evidence about how these things work.
So the challenge, I think, is that the cuts, if I totally get about the effectiveness of Search and Spark. I think the challenge, though, is as a local example, if a large percentage is cut out of not the Search and Spark, but the TPEP, I lose my coordinator.
Yeah.
So I think that's the balance, is that do you cut across the board in every county so there you basically lose the expertise you've had who's doing that work in reality to fund RFPs. And I'm just trying to look at it from a health equity point and across the state, and how do we kind of address the tobacco across the state. So, I mean, in reality, that's what would happen in Crook County, as an example.
But so I think we have pretty good data on what tobacco actually costs society in terms of loss of life, disability, what is it called, dailies, and all these kind of different metrics. I mean, if we could make a case, for instance, to, like, say, the CCO, that, because it's also one of the CCO metrics, and that it actually would cost the healthcare system more money to drop this program, that we're actually, until now, we've been able to assist the CCOs to achieve some of one of their metrics, then we might be able to maybe, in the spirit of collaboration and so on, actually try to see if some of the healthcare funds could be used for this preventive activity. It would achieve both of our accountability metrics.
And in the scheme of things, that's a drop in the bucket to their system.
Oh, of course.
And smoking rates among OHP beneficiaries are much higher than among non-OHP beneficiaries. So I think that just supports the economic.
Well, we have that from the BR, because we have the Medicaid BRFSS a couple of years ago, and we can compare that with the non-Medicaid or with the total population BRFSS, and we know that it's, I can't remember if it was like 20% higher or something like that in the Medicaid population, but it was very considerably much higher.
It was 20 percentage points, so it's about a factor of 3 larger.
So I'm going to just be a little bit of a devil's advocate here.
Sure.
So these are two separate conversations right now. One is the policy conversation, and frankly, I don't think we couldn't find anybody that would disagree with you. Number one. Number two, the money that was taken out of these funds went to fund Cover All Kids. So that's another public health goal, if you will. That all children in Oregon, regardless of their immigration status, will have access to care. So, yeah, I'm just saying that, it's not, no one is disagreeing with this. Right now, this is a funding issue, and we have to come up with a budget, and we have to do a distribution of funds that we have. So, I'm just saying, you know, this is the problem that we're faced with in the next, 30, 60 days.
But I think it's important for people to know both sides of the story. I mean.
Oh, no, I totally
Yeah.
agree, but I'm just saying that what Eli's outlining, we all know, and we've been working on it for years, you know.
Right.
And we agree, but the current problem that we're trying to address is how best use the distribution of funds that we actually have now, you know, for the greater good of everybody.
Right, so OHA is gonna be complying with the budget note, coming up with plans for how to best cope with this reduction in funding, and then we'll be bringing that back to FAB.
Yeah.
Reviewing costs, am I getting that right?
Yes, and one of the purposes of today's, you know, these things are all so abstract. I mean, you know, when we started the presentation, I think you were asked, so tell me what that means.
Right.
You know, what is a coalition? You know, what are you trying to achieve? And I think that the important thing is trying to get the options available for activities that are funded and can be funded going forward. That's the purpose of this presentation.
Right.
But we will have to come back.
Good, thanks. Katrina.
Yeah, so just a couple of questions. One is, I'm on to the next steps, but what is the role, again, of FAB or this committee compared to TRAC? So that's the Tobacco Reduction Advisory Committee. They're usually, or in the past, have been the ones who helped to figure out how funds available for the tobacco program were divvied up. Yes? So again, I'm trying to figure out sort of what the process is. I did want to make a comment to what Ely was saying. So yes, it's one thing to approach other potential sources of funding. You talked about CCOs. I'll just throw out there, I'm personally reluctant to use the money that was allocated for modernization, because a lot of that had to do with partnerships, and there's a whole process set up. And so to say, oh yes, we understand modernization, oh, but by the way, tobacco is a leading preventable cause, so we'll put that on hold. The legislature did say, we're taking money away from, they could have decided not to fund modernization and instead not take the money out of TPAP. And so I think it would not be true to the budget note if we second guess that decision. So, but I did want to understand what our role is, you know, what staff are producing and what TRAC does and what we do. And just one more comment, we've had a lot of discussions over the years about if we have reduction in funding, do we thin the soup or do we cut a specific, you know, a particular program? And so I want people to keep that in mind, because it may be harder to prove, oh, if we cut everything by, I think it's more like 15%, but will we notice it? Or if we take the chunk out of, let's say, the media campaign, will we suddenly see less of it, or out of the quit line or whatever? In other words, if we have to get back to the legislature about that this really did have an impact, it might be easier to show that if we took a chunk out of one of the 4 elements or whatever the comprehensive program is, rather than thinning the soup. So
I think Karen's going to answer my question.
you push the little speaker button.
The person, okay.
There you go.
Hi, I'm Karen Gerard. I'm the section manager for health promotion and chronic disease prevention section, and the Tobacco Reduction Advisory Committee is the advisory committee to the program, and we work with them in providing budget recommendations and programming recommendations for TPEP. With the budget note this session, it added bringing recommendations also to the FAB to discuss the same kinds of recommendations and to get feedback, and we do need to report back to the legislature on all of those processes.
So it will be both?
It is both. We are currently consulting with CLO, the Conference of Local Health Officials, tribes, the Tobacco Reduction Advisory Committee, FAB, anyone who wants to consult with us about how to absorb these cuts. We are.
So consultation is a little bit different than approval. So it's back to the sort of racy idea, you know, who gets to, and yes, you know, but giving advice or consultation or urban approach is a little bit different than bring the idea to us and we'll vote up or down.
So what I would like, I mean, a group like FAB to be able to do would have been to, for instance, point out some of the, let's say, if there were a calculation, like say, on the basis of what Spark and Search has been doing the last few years, that there was some kind of return on investment calculation where it was possible, where we would be able to actually say something about what this has saved the state in terms of either lives or sick days or hospital days or whatever. Because if that calculation exists, then I would have loved for FAB to be able to provide that as part of our response, so that it's not just like, say, I mean, because everybody can do an emotional response, I mean, but I would like us to be able to actually do an evidence-based or a data-based response. If we can't, then, you know, then obviously there's nothing to do about it. But I think it would be useful also for the legislators, I mean, because this is not the last time they'll be in this situation. But it might be good to be able to establish some kind of mode where they know that if they actually do this kind of stuff, they'll actually be told what it means to their own constituents in the long run. And I think that's sort of the only place where legislators are actually sensitive in a sense.
So Karen, is that some of the, is looking at ROI or sort of quantifying the health impacts of reduction in funding, so one of the things that the TRAC and OHA will be doing?
Yes, we definitely do that as much as we can, and as Katrina talked about, do you thin the soup or do you cut a component in its entirety? We have been directed by the best practices really to maintain as much of a comprehensive program shell and skeleton as we can, so we can add to it and, if necessary, take away, because there is no silver bullet for reducing tobacco use that does diffuse the ability to show that this cut led to this outcome. However, with Spark and Search, some of the policies that some of these grantees were working on were Tobacco 21, raising the age of purchase to 21. That really did lead to incredible pressure on the legislature this last session to pass Tobacco 21 at the statewide level. So even though it was isolated work in communities, it did have a great statewide effect, and we will see reductions in youth tobacco use because of that law. So that's an example of the ROI.
Yeah, thanks. Rebecca?
Yeah, so Kara, I think you said the plan was for this to go to the incentives committee, or that was your recommendation. And I wanted to point to the framework, I believe, that committee established for potential modernization funding. It was like a triangle, and they called something.
Well, it was a pyramid.
Pyramid, okay, yes. I think that would be a helpful tool to use in this conversation. It talked about where you put resources depending on scale of investment. I just wanted to comment, I think, on what you were saying, Katrina. To cut a big part of the program that's successful, to sort of show that there was a big impact due to a cut, I think would be in bad faith. You almost want to show that you can succeed with cuts, because as the tobacco program does its job, we'll see prevalence go down, we'll see revenue go down, so we're going to have to be having this conversation in the future anyways. Less resources, how do you have that end game sort of strategy, particularly for tobacco programs? So again, I really appreciate the evaluation results of these competitive programs, and I think it's really important to maintain programs that we know have demonstrated outcomes.
Yes, I just want to be clear. I wasn't advocating for one. No, I wasn't advocating for one or the other. I said that over the years we've had a lot of discussion. But to Muriel's point, is there a base below which you cannot go and continue to have a program? And that might be funding one person in Muriel's County or whatever. And so again, all I was saying was there was that discussion. Both should it be broader or should it be or should it be specific? And I whether it's media or Quitline or whatever that might show. But I'm with you that that doesn't necessarily show good faith effort. To Ely's point or whatever, the return on investment, unless things have changed a lot, the thing about tobacco is that it's one of these where people over the years have really wanted to know, so your youth campaign, exactly how many did it prevent? And you said, well, so yes, it helped youth, but you really need the adults to not smoke so it doesn't become, and oh, you need the media campaign and you need this. So it's very difficult to pull out and say, oh, the return on investment for this very specific component is X, Y, or Z.
Yeah.
And so if we cut this, you will have X number more, or the reductions won't be so much. So we all would love that, but at least with something like policy and tobacco, larger, it's very difficult to say this one policy piece had an impact, because it's usually the policy pieces within a larger, or the different program elements. So, but again, I'm not advocating that we cut one or the other. I was only making the case that if you thin the soup too much, it might be harder to prove that it was a real impact. But I'm with you, it might not be the good faith effort to do what the budget note says, which is how to maintain a robust program, but to the extent possible.
I think so. Well, we'll be talking about this, so I guess, well, I'm not sure, Karen, if your group is the one that's going to be bringing back the information, you know, help providing some of that quantitative background, either in your slides or even as background briefing for the board in the next time we talk about this will be really helpful. So I just like, if we have a couple of other quick comments, we'll do that. But I think we've done a pretty good job of priming the discussion for when this comes back. David.
I look forward to it coming back, because I think these are well-designed programs that were executed well, had impact, and I think it's very difficult for us in a 10-minute conversation to make a recommendation on how to cut the pie differently. And I would rely on the experts who are struggling with this on a daily basis to make a recommendation, maybe seek consultation and have a dialogue about it. But I think we could do more damage than good by making a specific recommendation on how to cut 20% off this program. I do like Ellie's point of saying, you know, if we could implement it through other parts of the healthcare system and move it over, that would be a success.
Yeah, that's the kind of thing that this board, I think, where its voice can be strong.
So just one little, I mean, this is really to the Health Policy Board in a sense, because we experience this in the system all the time, right? I mean, things get cut and so on, and sometimes legislators believe that even if they cut it, everything will just continue as usual. I think it really ought to be the Health Policy Board's task, I think, to actually feedback to, because you're sitting across all of the various committees that are active in the healthcare field, including the OHA for that matter. And I mean, it's almost like, it feels like you have to tell the legislators that if you cut a program, you cannot expect that this program continues unabated. It will have an impact. Doesn't matter what you do. If you take the money from somewhere else, you can still only use $1 one time. And I think that really should not come from somebody like us. It should really come from the Health Policy Board.
I think that's a good point. I think introducing really important programs like Cover All Kids should be done at the expense of other effective programs. And to introduce new programs requires new dollars rather than scavenging other programs.
Right. Yeah. All right. Thanks everyone, both staff for this information and to the board for returning to this next time. Thanks. Let's see. So we're a bit behind, but Kara, do you think we can do the
back the clock?
I love it. Do you think we can cover the charter quickly?
Yeah. So I'll give you a little context. A few months ago, the staff of the Oregon Health Policy Board from OHA, as well as all of the other staff for the other Health Policy Board committees, began meeting to try to streamline a little bit more the committee processes and procedures, both to help increase transparency with the public, so making it clear that we have a direct line. Of course, the Public Health Advisory Board was its own entity prior to 2015, but making it very clear our relationship to the Health Policy Board and making sure that we're kind of doing things in the same way. I think this has been really productive. It's been really positive. I've been able to share the guiding principles draft with our internal staff with that group, and there's been a lot of excitement about that. So it's really helping us diffuse information. And similarly, we had the conversation earlier today about the Health Plan Quality Metrics Committee. So they're another committee just like FAB of the Health Policy Board. So Some procedural things that are coming out of this work is just some basic standardization. And the first place that we've started is around the charter. So of course, every committee has had a different looking charter and a different format and a different way of doing business. So where we are moving to is a new charter template. So in your materials, you have our existing charter that we voted on earlier this year. It was approved by the Health Policy Board in April, and then the new template that we're going to be using for all of the Health Policy Board committees. This is really pretty much a cut and paste job, but I wanted to make sure that you kept me honest and you saw both versions in front of you for your materials today. So essentially what we need to do is approve the new version of the charter that's in the standard template. It will not need to go to the Health Policy Board for approval because the content that's within it has already been approved. And then after we've had a chance to do that, I can give you a little next step about bylaws. So are there any questions just about what this is and why we're talking about it?
So I'll just ask one question. So Kara, was anything added or subtracted in the reformatted version versus the old one?
Nope.
Thanks.
So the new one is the second one?
That's correct.
Oh, okay.
It's the one that just says Public Health Advisory Board on the top.
Okay, also deliverables and so on.
Sorry, Jeff, you kept me honest. I did add one item because as of House Bill 2310, on page 5 of the new charter, number 8, we do have a new member of the FAB, an individual who is a member of or represents federally recognized Indian tribe in the state. So I did make one change.
Okay,
And that was just to
thank you.
comply with the new statute.
Great, that's a good change.
Yeah.
Any board members on the phone have any questions for Kara about the reformatted charter? Okay, thanks. Any other questions in the room? Well, okay, I would entertain a motion to adopt the reformatted charter.
So moved.
Second.
Second. Okay, any further discussion? All right, I guess all in favor of adopting the reformatted charter, please say aye.
Aye.
Any opposed? Very good. Thank you. Yeah, thanks, Kara, for getting us standardized and formalized.
Yeah, so I'll just mention that our internal staff group actually meets on Thursday, and the next item in the list of things that we want to standardize is on bylaws. So some of our committees, some of our Health Policy Board committees do have bylaws. Others, like us, do not have bylaws. So I expect we're going to be getting some standard format by which we would develop and adopt those. So I will be having that come to us in October as a result of our internal meeting this week.
Thanks. Our last formal item of business is to ask if there are any members of the public who would like to make testimony. There are no members of the public who have signed up in person today to do so. So Angela, do we need to unmute the phone or?
It is unmuted.
Okay, thank you. So are there any members of the public who would like to make brief comments or testimony to the board this afternoon? Get any members of the public? Okay. Okay, thanks. Hearing none, we can close the public comment period. So one last item of business is when we will meet next. We're going to have our next FAB meeting in joint session with the Oregon Transportation Commission. that unfortunately, it can't happen. It looks like they are just overwhelmed, I would say, with trying to implement, you know, the priorities from the legislative session. And we were going to have a planning discussion about that, and I think it's just unfortunately not going to be able to happen next month. Am I summarizing that correctly, Kara?
Yes, and just to clarify, we are going to have our standing meeting time in October, and the session with the Oregon Transportation Commission was for November.
Oh, okay. Sorry.
Yeah.
Okay, thank you.
And just to clarify some logistics on that, we had moved our November meeting to Friday of that same week. We will pull you afterwards to just kind of pull whether it makes sense to move our meeting back to Thursday afternoon or keep it on Friday morning. I know part of the issue was the AOC conference that's happening in Eugene that same time. So I know several of our members were going to be involved in that. So we will figure it out.
Yeah, because I think some of us who are going to do that, we're just going to stay in Eugene and then drive
The
it.
same
What
day.
Friday was it?
I believe it was November 17th.
Yeah.
That's probably when.
That's
the
one
next
of them,
week.
yes. So we recognize there are a couple of different scheduling issues, and we'll just work on that offline. The point is, we're going to repurpose that November meeting time and take an opportunity down the road for a more in-depth discussion about transportation and health.
Okay, so thanks. So our next meeting in October will return to our regular third Thursday on the 18th, and staff will be in touch with board members about dates for November. Is that right? To
Yep.
confirm
Yep.
that. Good.
And then, because December, we had decided to cancel just because last year we had some weather issues and
Right,
things
I
like
remember
that. So there's apparently always something with trying to drive across on I-84.
Yeah, well, actually, so I appreciate board members' flexibility in being here today and having a really robust discussion, even though it was not a good day in logistics. So I think, given that, we can adjourn.
Thank you.
Thanks, everyone.
Jeff.
Well done, Jeff.